and you exhausted all the options we discussed yesterday. You gave him oxygen, you gave him high flow, and then a breather. You did everything there, and you still haven't, you're struggling. So you say, okay, this is one indication. What's the other indication? Confused. So you mean hypoxic, and he became confused. Okay, so still with hypoxia. So there are 3 indications, right? Roughly, or maybe 4. Hypoxia is 1. 2 is problem with the ventilation, right? His CO2 is going up, but with the BiPAP, whatever I did, and CO2 is becoming confusing, becoming unresponsive. So this is the second indication. Third indication is I have a problem with the airway. Glasgow scale is one of them. Though the evidence for Glasgow scale is weak. It's very weak. يقول لك لما someone at GCS is less than 9 intubate, there's no good evidence there, right? But we, as a physician, to play it safe, we say, okay, just put them on the intubation because your nurse is not, she's busy, or you don't trust your nurse, maybe she will leave him and he will aspirate, or so you put the tube in, just peace of mind. But scientifically, there's no good evidence there. I've seen people BiPAP in a neuro unit. I used to work with a guy who doesn't believe in this, so everyone goes on BiPAP. Anyway, so this is the third one. So airway, hypoxia or hyperventilation. And the fourth one is if you get someone with septic shock, you intubate them, right? When the demand is high, hypermetabolic state, right? When you have someone in a cardiogenic shock, you intubate them, right? So to cut down the work for breathing or help the patient, just put them in the breathing and knock them out so you can be in control. So this is roughly the indications. So this scheme is suggested by the Critical Care Society. What they say here, if you think your patient needs mechanical ventilation, yes or no, just run it in your head. If no, then of course you go to other conventional way. If yes, the first thing should come to your mind is what we said yesterday, non-invasive, right? Don't jump on the tube and put the tube in their throat, right? So first thing, say, hey, is he fit for non-invasive, right? If he is fit for non-invasive, go ahead and do the non-invasive first. Give it a try, at least a trial, all right? Unless there's a contraindication, and that's what they say in here. If there's no contraindication non-invasive, go for a non-invasive. If they do good, you're good. If they fail, you go and intubate them. If there's a contraindication, for example, your patient is septic shock and unstable. You talking to me? تتكلم فيه يا دكتور؟ Okay. The hemodynamically unstable, or there's any contraindication for non-invasive, the one we went over yesterday, then you so just keep it in mind. Keep the non-invasive in your thinking whenever you have a patient requiring intubation. So what can you control in mechanical ventilation? So you put someone in mechanical, what's the variables you're in charge of, right? So first one is stroke volume, right? You can decide how much stroke volume I want to give to the patient. And everyone knows what's stroke volume, right?
Tidal volume.
Oh, tidal volume, not stroke volume. So this is the volume of breath we give to the patient when we put them in a volume controlled ventilation. What's the usual number we use?
4 إلى 6 per kg.
Very good. So 4 to 8. We usually don't go to 4 unless you have someone with severe ARDS. So I would say 6 to 8. 6 to 8. If you have someone with a bad COPD, hyperinflated lung, if you give him 4 or 6, maybe he will not be happy. So you give him roughly 8, right? So this is, we'll go in more details on this one as well. Drive-in pressure or PD, or drive-in pressure or DP, or inspiratory pressure, there's different names they use for it. But if you use a pressure control, so this is for the volume, you use a tidal volume, right? For if you use a pressure control ventilation, you use inspiratory pressure. You decide, oh, I'm going to give him 20 of inspiratory pressure, I'm going to give him 30, I'm going to give him 25. Yeah?
Yes.
Rate is rate, right? So how you decide about the rate? Why you give this one 20 and you give the other guy 8?
تايد الفوليوم على
ventilation.
To control the minute ventilation. But maybe I need higher, your patient, some patient you intubate, they need higher minute ventilation. And some people, they need just, like me and you, they just need a normal minute. What's the normal minute ventilation?
7.
7 is high.
6
Probably 4 to 6 in average, depending on how big you are and how athletic you are. But so we decide about the rate based on the clinical scenario. There's no fixed number there, right? If you have someone with a high CO2, you want to wash it out, probably I give them a higher rate. If you intubate someone just to protect their airways and their lungs are healthy, normal, just they have a problem with the airways, I give them a normal rate. I give them like 10, 12, right? If you have someone, as we said yesterday, just came out of a cardiac arrest, right? So you want to just hyperventilate them at least for a short period, maybe you start a higher rate, right? So your decision based on what problem I have there, what's the diagnosis of my patient, right? There's no fixed number, but the range is probably between 12 and 20. We can go higher in numbers. In what disease? ARDS, right. So if you look, everyone should read this study, the ARDS.net. Just Google it, ARDS.net trial. This is done again in 2001, published in the New England Journal of Medicine, and it is the جانب يقولوا this is the Bible, هذا القرآن بتاع ال ARDS أو الكتاب المقدس تبع ال ARDS. Just read it, right? So this is and this is where you find the table for the PEEP. Remember in PEEP yesterday, PEEP FI2 PEEP table اللي حكينا عليه موجود في الستادي هذا. Flow rate. You see flow rate, which mechanical mode of ventilation you see, you have to adjust the flow rate? Volume, right? So in pressure control, there is no flow rate. There is inspiratory time. But here, there is a flow rate. And the flow rate is how fast you blow there, give that tidal volume. And we always, not always, but we tend to be, or the whoever put in the ventilator, they do 30 liters, 40 liters. That's not enough. Always aim for higher, 60. 60 liters. Everyone wants to breathe comfortably. I want to take my breath very quickly and then enjoy it, right? But you don't want to have to slow breath, especially in someone who is intubated and already distressed and he's not happy and his tube sticking in his throat and you deprive him of the his tidal volume. We'll talk more details about this. Oxygen. You can do that if you have someone who's tiny, Down syndrome اللي تحكي عليه هذا. If it's a small, tiny person, probably he doesn't need 60. But you can start at 50 and go up. Like in an average, most patients, they are happy with 60 and higher. أكثر المرضى 60 and higher. Oxygen is oxygen. So always start with
100.
Default about 100%, come down ASAP as soon as possible. Don't leave it there and go home, right? So drop it as soon as possible. Trigger. Anyone knows what's trigger?
أمتى الميكانيك فنتيليشن خلي المريض ياخذه. أمتى الميكانيك فنتيليشن يعطي فرصة للمريض أن يحس يعرف أن المريض بياخذ.
غير مثلا السباب لعند
حسب المود.
There is a trigger for the breath and there is a trigger for the ventilator.
Yes.
Right? The trigger for the ventilator is what he said. It's how easy the ventilator make it for the patient to breathe. Sensitivity. In other words, this is sensitivity, right? And the number ranges between maximum is 2 and you
5
can bring it down. So if you make it harder for the patient to trigger the ventilator, for example, in volume assisted or pressure assisted, and he's trying to breathe and the machine just doesn't care about him, ignores him, then he will struggle and you will see the patient is struggling to take a breath, and you see in the graph a lot of up and down in the volume and the pressure, and this is what we call asynchrony, right? They're not working together.
Yes.
And the nurse comes to you, say, hey, there's a problem there. So what do? we as a physician, what we tend to do?
Decrease the trigger.
No. What do we do?
Decrease the trigger.
Trigger.
No. We don't look at the trigger. This is the reality. What we do? We sedate the patient, right? Increase the sedation. Give him a propofol. Give him whatever. Is that right? We don't look at the machine. This is one of the problems we have. Always look at the machine. If you have asynchrony, say what I'm doing wrong there. Why my patient is not happy there? Why they're not working together, right? So always don't give sedation, especially.
التريجر هذا مثلا واحد يداويني ولا شيء إذا منه التريجر هذا تشوف ان المريض يقدر ياخذ بروحه ولا هو نفس هذا؟
لا مش نفسه.
مثلا من الساين في بتحول على السباب بدك سنتويشن.
We'll cover the pressure support. You mean? Yeah, we'll do it later. But this is not the one we talk. This is the, maybe I wrote it wrong here. The sensitivity. Forget about the trigger. Look at it as sensitivity. How sensitive the machine to the patient is trying to trigger the machine, right? Then في الvolume ولا في pressure control. This is the two modes we will cover today. You have a preset rate. You say I want this patient to breathe 12 times a minute, right? So this is the rate I decide there. Salam. But if the patient wants to breathe, the machine will help him. Okay, so this is the beauty about it. This is why it's called assisted control. Control is the control of the machine. Machine controls the 12 breaths. If 12 breaths will be, that's the control part. The A stands for assisted. If the patient starts waking up or he's not getting enough there and he wants to take a breath, he will trigger the machine, right? And the machine will give him the full tidal volume, give him the 400, right? So he will be happy there. واضحة؟ all the assisted control. Assisted control with SIMV and here our controlled modes, let's put it this way. Whether volume, whether pressure, with this SIMV, AC or PC, we will go over it. But most of the machines it's there, yes. Where we are, here we are. Mode of ventilation. We tend to struggle. We say, hey, what mode of ventilation should I start for this patient? Volume or pressure or adaptive or bi-level or name it. Different modes. Salam. Here's something keep in mind and always think about it. Don't worry about them. Whatever mode of ventilation you've seen, you're comfortable with, you've used, you know how to troubleshoot. If something goes wrong, you know how to deal with it. This is the mode, right? Because in reality, there's no difference between these small, tiny difference. It's not gonna make a difference for you when you intubate the patient in the emergency room or as بعدين خلي الموضوع بكرة وبعد بكرة تشوف لكن there's no difference between the modes of ventilation. There's no big difference. So if you've seen volume control, you worked with it, you know how to deal with it, this is the mode you use. Anyone tell you something different is wrong. Okay? So mode of ventilation is what you are comfortable with, what you've used, what you have experience with. Is that clear? So we should not worry about the mode of ventilation. Whatever you're happy with, comfortable with, use it. Any questions so far? Okay. Now this is the important stuff. Peak airway pressure, because you'll hear about it. The machine will start beeping, making sounds. Peak airway pressure is high. Nurses will call you. Peak airway pressure is high. You should know everything about few pressures here. So peak airway pressure is the pressure at the end of inspiration, and it reflects what?
Compliance.
Resistance.
Resistance.
Airway.
Both resistance and compliance.
Compliance.
So if there is only resistance, it will be high, and the plateau pressure, which we'll see shortly, will be normal. Okay. If there is a compliance problem, both will be high. Okay. So remember these two things. Sorry. في الفرق في البلاتو, yeah. And I'll tell you strategy. You do it when someone calls you peak airway pressure is high. It was 35 and now it's 55. تعال يا دكتور شوف ايش المشكلة. Okay. So it represents both airway resistance and compliance. If it's high, doesn't mean there is a resistance. You have to check the plateau always. Whenever they call you, say the peak airway pressure is high, the first thing comes to your mind is, okay, what's the plateau pressure, right? So you go to the ventilator and you check it, or if you have someone who can do it for you, say, I need to know what's the plateau pressure. Then you decide, is that compliance or is that resistance? PEEP is PEEP. We spoke about it yesterday, so we didn't have to spend more time. Anything not clear about the PEEP? And it's there all the time. It helps to recruit. It opens the lung. You have to pay attention to hemodynamics if you're using high numbers there. Risk of paratrauma is there, but it's not high unless you're using PEEP of 15 and 20 and so on. Okay, skip this part. Plateau pressure. So two things you remember, or three things about the plateau pressure. One, if you have a high peak airway pressure, you need to know your plateau pressure, and we all understand this part, right? Second thing, the plateau pressure represents what pressure in the lung? Alveolar pressure. Perfect. So if the plateau pressure is 25, your alveolar pressure is 25, right? If it's 55, your alveolar pressure is 55, and this is bad. And the third thing you remember about the plateau pressure is, what's the value? Less than 30. Always less than 30. Whether you intubate your patient for ARDS or patient gone to the OR for hernia repair. Any intubated patient, plateau pressure should be less than 30. That's well documented, well studied. It's everywhere there. Now this is the trend. Okay. All pressures in the ventilator will be measured in centimeter water, not so it's not millimeter mercury like what we do with the cuff blood pressure. It's just a piece of information there. So okay, compliance. What's lung compliance? We hear a lot about compliance. What do we mean by lung compliance?
The ability of the lung to get spared.
To accommodate the volume or the pressure you're given to it, right? We have two types of compliance, if you remember what we said yesterday. Static and dynamic. As a physician, which one is important for us? The static compliance. What's the normal? Very good. I'm happy you remember. The static compliance, what's the normal value?
20.
Nah, 20 is bad. 20 is bad AR.
More than 20.
60, right? 60, around 60, that's the normal. So if I come to you and say, I have a case of ARDS, and the first thing that comes to your mind, okay, what's the plateau pressure, because you want to protect the alveoli, I say it's 25. What's the compliance? I say 18. Is that good or bad? Bad, right? So that's tell you about the severity of the disease. This is a severe ARDS. How does it help you? So when you ventilate, you make sure you give small volumes, right? Because you don't want to stretch that stiff lung, right? If you're given a pressure, you give a small pressure, the minimum pressure which will keep your patient oxygenated, right? Or the minimum volume. So this is how you think, right? And even when you talk to the family, we say, hey, we have a bad case of ARDS here, and we will do what we can with the ventilator, but it's really critical. It's a very sick patient. Blah, blah, blah. So this is the way.
هل في معادله معينه تخليني مثلا نقول الكومبلاينس فلاني لما نحسب له تايد الفوليوم بطريقه كذا وطريقه كذا؟
Yeah, you can do the tidal volume. Look at the exhale tidal volume.
تمام.
Do your plateau pressure. Take the PEEP out of the plateau pressure. Let's say the plateau pressure is 25, and you give him a 5 of PEEP.
Good.
Okay, so the difference is 20. Your exhale tidal volume is 400. Divide 400 by 20. Okay. So this is the, we did the definition already. It's change in volume over change in pressure. Okay, one more thing. Which is good? High compliance or low compliance?
Higher.
High compliance. So emphysematic people, they're good.
هيك كده خير الامور
That's it. So high compliance is bad and low compliance is bad. So you need a normal compliance. So emphysema is a high compliance, but they're struggling, right? So this is something you should remember. The aesthetic compliance, we said that already. Dynamic. And this is just academic, you don't have to worry about. This is how you calculate it. No, there's something missing there. This line here. So the static compliance tidal volume divided by plateau minus speed, whilst the dynamic, which we hardly use it, is tidal volume divided by peak minus peak. All right? It's a very easy equation to remember. This is the normal dynamic, and this is the static one. Any questions so far? If you understand the basic, these definitions and what you're dealing with, will make it easier for you to know the dynamic and deal with the problems later on if you have someone in mechanical ventilation. Okay, what clinical conditions can decrease your compliance? Make your lung stiffer, make your lung difficult to understand it first before we start saying. Okay, fibrosis, go ahead. What else? Pulmonary edema. ARDS. Bad consolidation. Okay, atelectasis. Keep going.
Neuromuscular disease
Nah. Okay, pneumothorax, because we see a lot in the ICU, right? So think about it this way. Anything stops the lung from expanding. So if you have a large effusion, that will be a problem for the compliance. If you have a pneumothorax, if you have someone came in from the OR yesterday, they brought the patient to you in the unit, had some bad abdominal surgery, and his abdomen is distended that big. Will he have a low compliance?
Yes.
Why?
Sensitivity.
Because everything pushing the diaphragm up, right?
Yes.
You tend to forget this part. So anything pushes the diaphragm up, abdominal distension, ascites, ileus, whatever it's there, will cause low compliance. So anything squeezes the lung will cause low compliance. Then you can come up with tens of diagnosis. Okay? What can cause your airway resistance, not the airway, peak airway pressure to go up?
Airway resistance.
Right? You said something. Kinky tube, yeah. Anything tube secretion.
narrowing اي حاجه تدير narrowing.
Narrowing the airways, very good. Bronchospasm, asthma, plus whatever we said on the other. Anything affects your compliance will affect your peak airway.
Yes.
Okay. Okay, airway resistance refers to the resistive forces encountered during mechanical respiratory cycle. So this is the peak airway pressure we just mentioned. This is the normal, don't worry about it. Okay, you should remember this graph by heart. If you have someone in a volume control, this is the kind of pressure, not exactly the same, but I think I have a better one. No, something wrong with this machine here. Here, this is what I mean. Yes, this is the one. So, pressure, time. This is the pressure curve in someone having a volume controlled ventilation. Okay? So, you start with the PP5, your patient will start breathing here, takes all the breath in. At the end of inspiration will be his peak inspiratory pressure. You paused for 5 seconds, you will have your plateau pressure. This portion resembles or represents the resistance, and this column represents the compliance, right? then they exhale again. There's more you can find out or come up with from this curve, but let's stick with this one for now.
دكتور معلش شو الفكرة في البوزي؟ ليش مش طولي كمان؟
Okay. The pose is
قصدي الماشين اللي توقف المريض نفسه هيك تخليه
لا مش
يرتاح.
الماشين. You have to do it.
في بطن.
There's two ways of doing it. You can, some ventilators, there's a button, you can press it and it will hold the breath. Just close the circuit.
توقف بعد
Close, yeah, and that will show you, and it will actually give you the number, the plateau curve, tell you the plateau pressure is 31 or 35. Right? And there's another machine, you stop it, then you have to do it manually. I don't know. No?
بس احنا عندنا
Okay. You have inspiratory pose, you have expiratory pose, right?
بالضبط.
So inspiratory for the plateau and expiratory for the O2P. Okay? Okay. So anything, what's the difference between these two? What's the normal difference? 5 to 10, right? If it goes higher than 10, that means we're having some airway problem, right? If both are high, we have a compliance problem, okay? You will see it in exams, you see this board in all kind of courses, this curve here, and you will see it in your ventilator as well. Any question? And this one, I'm just showing you here the resistance, so the plateau will be normal, but the peak airway pressure will be high. So all the information you get from your colleague or from the nurse, say, hey, peak airway pressure was 30 here and now it's 55. You come and you check the plateau. If your plateau is normal, oh, this is a resistance problem. So what do you do then?
نشوف التيوب مثلا كده ورا لا نشوف الريزستنس نسمع.
You listen to your patient, make sure there is no wheeze there. If someone has asthma or airway disease or whatever, can give bronchodilators. Someone, your colleague put a central line and he goes home, right? And he punctured the lung, for example. There's a pneumo there. You look at the tubes, make sure it's not underneath the table or someone standing on it. Patient is not awake and he's biting the tube, for example, maybe he needs more sedation and like paralysis or whatever, right? So this is, if you have a compliance, see again, look at the examine the patient, examine the system.
بالبلاتو شو يعكس في الواقع يعني؟
يعكس the alveolar pressure. Huh? So if you have someone, this is the airways, this is the lung, the alveoli here, right? And you get the pressure here. If you close the circuit, if you stop everything, there will be a column of air, من airways, all the way to the last breathing unit, which is the alveoli, right? Pressure here, equal pressure here, because they eliminated the resistance. There is no resistance. Everything is static there, so this is the difference. If the flow is going up and down, you have to add a resistance to your equation, right? If there is no resistance, just block of air sitting there. Pressure here, pressure, you measure the pressure here is 30, so the pressure here will be 30. It's a physics. Physics. So it represents your alveolar pressure. Okay. Any questions so far? So inspiratory, expiratory time, we went over it in details yesterday, right?
Yes.
So if you put your patient on 20, I'll make it easy, 20 breaths per minute. I say I want my patient to breathe 20 breaths per minute, okay? And you say I want my ratio to be 1:1. How much time he spends in inspiration and how much time he spends in expiration?
1.5.
Very good. So very smart. So, and think about it this way. So if you do say I want a 1 to 2, then it will be 1 second inspiration, 2 seconds expiration, right? If you prolong one arm, you shorten the other one, right? So if you want your patient to spend more time, you have a COPD patient, CO2 retention, tight, very wheezy, just intubated now. So I'll make their expiratory arm longer. So I'll blow the air fast, or so I can make the expiratory arm long. And we'll expiratory time, okay, expiratory time. The ratio, we went over it already. The I ratio can be directly or indirectly. So how we can make the I shorter or longer?
أنا أتحكم في الفلو.
Very good. So indirectly through the flow. So if I want to make it longer, what should I do with the flow? Shorter or longer?
قلنا اللونجر معناها
لا longer.
الفلو بشوي سلو.
If I want to make it
لونجر معناها سلو فلو.
slow flow, very good. So I'll slow it down to 60 liters. I'll make it 40 liters because I want to keep the air inside. I want to have a hypoxic patient. I want a more gas exchange, right? If I want to make the E longer, I'll make it faster, right? So very quickly, and I give more time for that particular breath to. Okay, this is one. What's the other ways of doing it? Some ventilators, you have a knob there. Just tell you what IE ratio you want, and you have just to change it by hand, right? The old ventilators. And the third one is by slowing down the breathing. Okay, indirectly you can change the ratio. Okay, and remember this is a statement. Changing one will affect the other one. All right, flow. We said that already, right? Peak flow rate, how fast we give that tidal volume. And peak flow rate works only with the volume controlled ventilation. Okay. So what I'm going to go over now is more of academic, but it's good to understand it. What they call anatomy of the breath. When you take a breath, or you give the patient a breath with the machine, you need to know about 4 things. What triggers the breath? What's the target? And what's the cycle? And what terminates the breath? And the 4th one is not important, the baseline, where the breath starts. But in volume is different from pressure control, different from pressure support. If you didn't understand it, just walk away. It's not going to change anything in your practice, but maybe you can read about it later on. I'm going to show you the curve. Why the graph's not showing up? Here. So there is a trigger. What starts the breath, right? How the machine starts the breath? The trigger. What's my target with the machine when I give a breath? My target is a volume. I want to give 400 of tidal volume, or I want to give like 20 of pressure. What's my target there, right? And when I get my target, what should stop the machine from doing more work, right? Which we call cycle or termination of the breath. Expiration by the machine is always passive. The machine have no business with the expiration. It will give the inspiratory part and stop, and let the patient exhale by himself. Mm-hmm. So the expiratory part or expiration part, the machine have no role. So trigger when the inspiration begins, or what starts the inspiration. Target, what's my target with this breath, what ends that breathing, and the baseline, don't worry about it. So the trigger, what initiation, or how we initiate the breath. There's 2 types of trigger. Either the patient, he wants to breathe and triggers the machine. If the patient does not trigger the machine will give the breath. And how the machine decides about when to give the breath? Based on time, right? So you tell the machine, I want to give this patient 10 breaths every minute. So every 6 seconds, the machine knows I have to give a breath. I don't care. Patient breathes, doesn't breathe, I'll give the breath. So this is what we call time, right? So this is the trigger. I think that if you remember this part, that's enough. What's the target here? What's my target? What's the machine's target here? The target is to give the preset tidal volume. I want the patient to have 400 of tidal volume with each breath you give. So the machine will target 400 tidal volume. Or I want the pressure in the airways to raise to 20 every time you give the breath. This is the pressure control. So the target of the machine is, once it hits 20, oh, the machine will say, I reached my target, I'm done. You can exhale, okay? And cycle, what terminates
Time.
your target, right? So the pressure or the flow, or the flow, it happens with the pressure support ventilation. And I don't want to confuse you here, baseline, skip it. Okay, we'll have spent some time on the waveforms, the one you see in the middle of the screen, your screen. I don't know if there's a good waveforms here, but there's three types of waveforms you see with any ventilator, especially with the newer one, the Hamilton and S1 and S5 and this fancy one. So you can see scalar, which is basically time against the pressure, time against the flow, and time against volume. And we'll see some pictures. You can see loops, and the loop is either pressure time or flow time. And I'll show you some examples. So this is the typical story of any regular ventilator. You see one for the pressure, you see one for the volume, and you see one for the flow. And by looking at the graph, you can decide, or you can say, this is a pressure controlled ventilation, this is a volume controlled ventilation, and how you do that. So for the pressure, and we'll see some examples again later on, volume will look more or less the same in all ventilators, whether pressure or volume or whatever it is. But from the curve of the pressure, you can say this is a volume or this is a pressure. In volume, you will see it because you in volume you're gonna give a. Remember, in volume pressure, I'm talking too much now. Volume controlled ventilation, you have control over the volume, but you have no control over the pressure. So your machine will know, I'm gonna get 400, but I don't care about the pressure, and the pressure will depend on what?
Compliance.
And your lung
Yes.
dynamics, right? How's the airway resistance? How's the compliance? How sick is the lung? So the pressure will vary, and this is why we go back and measure the plateau and peak, and we spend a lot of time there, right? But in pressure, you guarantee the pressure, right? And you didn't have to do all these measurements we did earlier, because your peak pressure would be the same like your plateau pressure would be the same, just flat, would be square like this. Your pressure would be square, right? Because you decided how much pressure you want to give. But your volume will be variable, right? Not a big variation, but it will be variable. If you see this negative inflection here, means what?
Trigger.
Yes, that means your patient is triggering. Is that clear? Right. This is not a triggered breath. This is a triggered breath. Why we say it's triggered? Anyone?
Negative.
ماشي للنيجاتيف.
Yeah, because the patient trying to inhale, right, goes negative. The machine will sense a negative flow. Patient is sucking in the air, so it will trigger the full tidal volume, because this is a volume one. Okay. Flow. This is the inspiration arm. Maybe I can use this pointer here. Inspiration, and this is the expiratory part. Always remember the expiratory part should touch the baseline. If it's not touching the baseline, means what?
What to be?
Double.
Air trapping.
Means there is some air, extra air. The patient is not able to exhale everything. Either you're given a big tidal volume, or you're doing like a right main intubation, all the air goes to one side, right? Or your patient is breathing too fast, your rate is too fast, you didn't give enough time for the air to be exhaled, right? So think about air trapped inside the lung. Why my expiration arm is not touching the baseline? Someone say something? No? Okay, so we'll talk more about this. The second graph you will see is the volume pressure curve. And basically with this, a new one, or not a new actually, but it's been there forever. But with the new ventilators, you see this kind of معانا؟ ها؟ تأخر يا شيخ. Okay, so this is the inspiratory arm, expiratory arm. The machine will give you this picture here, and it will give you, we can get a lot of information from this graph, we'll go over it later on, but basically it will tell you about the lung compliance. Does he have a good lung compliance? If this is the place, this is the lower inflection point and the upper inflection point, the one we discussed yesterday, and your ventilating, safe ventilator should be in the middle here. The third one is, you see it with some ventilators, is the flow loop, which is volume and flow. That will tell you about the peak expiratory flow. For example, in this one is 1200. It will tell you about the inspiratory and expiratory flow both. This is the inhalation arm, this is the exhalation arm. You can get a lot of information. This one you see with the, if you did a pulmonary clinic, if you do a pulmonary function test, you will see this kind of graphs there. And the pulmonologist will say, oh, this is a mild COPD, moderate severe, based on the FIV1 ratio, FEV1, FVC ratio, right? But this is not what you need in the ICU. I don't care if it's severe or not, but it's just give you some information there, okay. So in volume controlled ventilation, I don't think we need to do this. I'm just going to confuse you more. I'll skip this one. Flow shapes. Why? Here we are. So, now based on what we said, what's going on here? First of all, is this volume or pressure?
volume.
It's written there, right? So volume. With the volume, the flow always a square. This is another way of saying this is a volume. The flow will be square. It comes in different ways, but most ventilators now comes as square wave. And the pressure will be decelerating, when they call decelerate, start high and slowly coming down.
كأنه زي حرف البي حتى شوي يتذكرها.
حرف ايش؟
البي نفسه هو.
هذا
هذا الجزء العلوي منه يعني.
اوكي.
خيرك واسع.
This is a flow on what kind of ventilation here?
Volume.
Volume. Very good. And what's the problem with the flow here?
مش كلها.
It's not touching the baseline. That means my patient is not able to exhale, air trapping. So if I leave this, if I see it in the morning, I walk into the unit and I see, oh, there is a problem with the air trapping, and I walk away, and the nurse will call me back 2 hours later. What would be the problem?
Hemodynamic anesthesia.
My patient is tachycardic, hypotensive, becoming hypoxic, right? So always deal with it, right? Say, well, my patient is autopepid here, right? Why have it, what we call intrinsic PEEP or autopep or air trapping. So always deal with it. Okay. How we deal with it?
ممكن increase expiratory time مرات.
Okay, the increased expiratory time is one.
Or reduce tidal volume.
You can do that, but that will be the last thing because you want to ventilate your patients, right? Most of these patients, they are COPDs already, right?
نفس البيب.
So they are COPD. So if they're COPD, they have CO2 is high, and you want to ventilate them. So you're in dilemma. Should I come down in the tidal volume? But lowering the rate is one.
البيب.
Slowing them down a little bit. Okay. Two.
البيب اللي نحطها بنقص. setting بيب.
Maybe just make it worse for you.
لا بنقص مثلا السيتنج اللي غير شيء. هو ليش بيضيف اوتو بيب؟ انا اعطيش بيب.
سلام ورحمة الله. مرحبتين. الله يسلمك. شو اخبارك؟
انا مش مهندس بتاع الشيء.
مرحبتين بك.
لا
So ratio is 1, rate is 2. The problem with the ratio is sometimes it's a little bit challenging, but okay, you can do the ratio. You came late yesterday, you came late today, Doctor. We're supposed to start 8:30. And wallahi, and the most thing I hate is someone not committed to their time. Okay, معلش. So rate, IE ratio 2, 3 is, just think, it's,
طيب volume.
you can come down in tidal volume. That would be the last resort for you, or resource for you. Okay. But if my patient is becoming hemodynamically stable, like as I said, his heart rate pumped to 130, blood pressure is 90/60, saturation came down from 95 to 86, and they call me, and I look and there is O2B. What's the first thing I do? Disconnect, right? Why you disconnect? Why we disconnect? The common sense, guys. So all the air will come out, right? Air under pressure in the lungs, inflated lungs, trapping there, air will come out, right? And when the air comes out, blood will gush in, go to the right side, blood pressure start coming up, heart rate coming down, right? And bag your patient. Put the ambu bag there and bag them slowly, very slow, just to get the saturation up. Then put them back on the ventilator and do whatever you said. Say, okay, rate was 30, now let's come down to 25 now. So we prevent this from happening again, right? Let's make the IE ratio longer, so we give more time for exhalation, right? So this is how you deal with the O2P. O2P, you can see it in chronic COPDs, for example. The minute you put them in the ventilator, there's some O2P there. If they're stable there, leave them alone, because this is where they live. They live with the O2P. They're always hyperinflated. They're asthmatic or they're emphysematic patient, right? But if start creating problem for you, you have to deal with it. Any question?
Rated it for here.
Rate, you just bring it down. So if you slow down the rate, you will give more time for exhalation. And questions? Yeah.
مثلا في حالة زي مثلا في النيموثوراكس. الاكسبات الزيت ما تحطش البزمان. في دير مثلا كما نقول في حاجة ديرها في الجهاز نفسه ولا مثلا يبي تشتيوب الموضوع يعني.
Pneumothorax, there's only one answer for it. Deal with it. Chest tube. You will not have O2P when in pneumothorax. You will have what they call air leak. You have air leak in the graft, and you will have what else you see in the pneumothorax and your pressure curve. خليه هو هنطلعك برا لو ما جاوبتاش لانك كنا نحكوا فيه تو. What will happen in pneumothorax if you have someone in a volume controlled? This gentleman, he put a central line and he goes home and the nurse calls you back and say, hey doc, the peak airway pressure is 60 now. What you will do? You want to check the plateau. The plateau is 50. What's the problem? خليه هو. So your peak airway pressure is high, plateau is high, and there's a story behind it saying Dr. Fulan, he put a central line for him. Before, and I want you to see the X-ray. If you see the X-ray, what you will see there? Pneumothorax, right? Because the compliance is gone, numbers are high, there's a good story behind it, and the X-ray shows there a pneumothorax there. Without seeing the X-ray, if I get this decent story, good story, I'll stick a needle there. Okay? It will change. As if you remember earlier, we said if we change the flow, we affect what? If I give you the flow faster, what will happen to the eye? Yeah, the flow, yeah. One of the things you can do, yes. So the IE ratio can be affected by the flow, by the rate.
Direct or indirect?
Yes, direct or indirect. Thank you. Okay, shall we move on? You good? Okay. So when you put someone in a ventilator, as we said earlier, we're just going to do pressure and volume. This is a basic course. So for the pressure control, the variable sets, so the PIP, the rate, it's more or less the same in both. It's just a summary of what we said. All right, so before you leave, you go home, you need to remember all of these. I'm kidding. No, you don't have to. So this is just the abbreviation: continuous mandatory ventilation, spontaneous, volume controlled, pressure controlled, AC with the volume, and so on and so forth. You don't have to remember this. Moist ventilation. And this is the name given in different ventilators. Do we have to remember all these names? Of course not, right? No one remembers these names. So if you look at the CMV, volume controlled, in Mackay they're called VC, in Draeger they're called VAAC, in Hamilton they're called CMV, and so on and so forth. In Pennant, this is what they call it, right? And different one, different names. So you didn't have to remember. If you remember 2 or 3 names, controlled mandatory ventilation, either volume or pressure. It's easy, right? Either I use a volume or I use a pressure. Or who uses SIMV here?
كل نستخدم أكثر حاجة
اكتر
استخدمها
مود هو اشهر مود.
That's the most popular.
يس.
هذا اللي
هذا جاي عشان
جايب عشان تقول تستخدموه
كيف؟
جايب تقول لنا ما عشان تستخدموه
I don't use SIMV. It's out of date SIMV. No one these days uses SIMV. It's a horrible mode. I can talk about bad things for the rest of
والله
the day.
المرضى يتحسنوا
ها؟ يحسن المرضى؟
بالسنة أنا فاكر
Okay, but نعم.
كم ليك سنة وأخذت
By the time you leave إن شاء الله اليوم ولا بكرة
ما تقولش
you will never use SIMV again. إن شاء الله. I'll try to
كم ليك
convince.
سنة وأخذت السنة؟
نعم.
كم ليك سنة وأخذت السنة؟
والله أنا ممكن I find people in SIMV.
15
No, this what I practice the surgeons love SIMV. I don't know why. Anesthesia people love SIMV. So probably this is where you get your knowledge and experience from. Then you can tell ICU is here covered by anesthesia, صح?
خلطة هيك
Yeah. Who's doing anesthesia here?
أنا مع السيرجيكال لكن emergency medicine أنا الوحيد
And you're,
أنا
you're,
فترة.
you're surgeon?
لا لا emergency medicine
Emergency medicine. Anyway, so you'll have to remember these names, and I'll tell you a message at the end here. Don't worry, you don't have to remember these names. Always get familiar with your alarms. Alarms on your ventilator, right? There's alarm for everything. There is alarm for low pressure, high pressure, low PEEP, high PEEP, low volume, high volume. And so spend like 1 minute or less than 1 minute looking at the alarms of your patient, adjust them. So that will make your life easier. Okay? And this is the end of part 1. Any questions? Okay, we can have a 3 minutes break.